All right, well, good afternoon, everybody. Thank you for spending part of your Wednesday with us. My name is Matt Lopez. I'm the Regional Sales Director with Levo Medical. It's my pleasure to welcome you all to our webinar here, Overcoming Tinnitus While Patients Sleep. Over the next hour, next slide, please. Over the next hour, we'll provide a brief review of tinnitus and the role neuroplasticity plays, discuss the biology of the auditory pathway and how it remains active during sleep, provide some benefits of acoustic sound stimulation for tinnitus sufferers while sleeping, as well as leave some time for questions at the end. If you do have any questions throughout the conference, please feel free to write them in the Q&A tab, and we'll address as many as we can at the end of the session. Following this webinar, we will be sending out an email with the link to the recording of this session for future reference. Next slide. I have the pleasure of introducing the two presenters this afternoon, Dr. Kelly Breese, owner-operator of a multi-location practice in Sarasota, Florida. Has a huge passion for tinnitus management, providing evidence-based care for her patients. Kelly has been a provider of the Levo system for a number of years, and I'm excited for her to share some of her success stories with us today. Next slide. Dr. Daniel Drexler joins us today from Montevideo, Uruguay, where he's currently the director, owner of a multidisciplinary tinnitus center. Daniel is one of the original founders of the Levo system, brings over 30 years of experience in research and clinical practice in the field of audiology. So I'm very honored to welcome Dr. Daniel Drexler.
Good afternoon. My name is Daniel Drexler. It's a pleasure to be with you in this webinar. Today, we are going to address different aspects of tinnitus therapy with Levo system, with special emphasis on the scientific basis of why it is performed during sleep. Let's start addressing basic concepts about the genesis of tinnitus and current ideas about its treatment. Regarding tinnitus, genesis and treatment occurs what we have called the tinnitus cycle. Tinnitus is originated by neuroplastic changes at the auditory system that, in the vast majority of cases, were triggered by decrease of cochlear inputs caused by a lesion of outer hair cells at some level of the cochlea. But there is good news. The last few decades, we have learned that using proper acoustic simulation, we can induce neuroplastic changes, but this time aim to reverse the previous changes that originated tinnitus, and in this way reestablish the balance between excitation and inhibition in order to decrease tinnitus intensity and annoyance. So what is neuroplasticity? Neuroplasticity is the ability of our brain to reorganize itself both structurally and functionally. Since the beginning of the 20th century, Santiago Ramón y Cajal, the founder of neuroscience, had established that nerve connections are neither definitive nor immutable, and that is the experience itself that sculpts the neural networks. It is the repetitive flow of information that creates preferential highways, creating new synaptic connections, strengthening the synapses that are used the most or weakening those that fall into disuse. To understand the neuroplastic phenomena underlying tinnitus and its treatment, let's imagine that during a long period of days, we have to cross this soccer field from point A to point B. What is the most efficient path? The diagonal. But the first days, we find 2 puddles of water, so we follow this path. And the following days, we continue following this path, creating a footprint. After a month, the 2 puddles dried up, but since we got used to walk on the footprint, we continue to follow the less efficient path. How do we walk the diagonal again? This situation is analogous to what happens with the treatment of tinnitus. A non-efficient circuit was created that ends up generating tinnitus. How do we get our brain to reprogram itself to return to function efficiently? Let's now make a brief overview of the central auditory system to remember the complexity of the structures that are at stake. On the one hand, we have the afferent auditory pathway. In this figure, we can see the scheme of the different nuclei that make up the afferent auditory pathway and its location at the level of the brainstem and the nuclei of the base and the cortex. The resting potential changes of the inner hair cells are transmitted first to the ventral cochlear nucleus and the dorsal cochlear nucleus. From that point, much of the information crosses into the contralateral pathway and successively reaches the superior olive, the lateral lemniscus, the inferior colliculus, the superior colliculus, the medial geniculated body, the primary auditory cortex, and the secondary areas and areas of association at different levels of the brain, such as the prefrontal cortex, the limbic system, etc. And running in parallel to the afferent system and cascading down from the auditory cortex to the cochlea is the efferent auditory pathway. The efferent system modulates the activity of each one of the synaptic stations of the auditory pathway, adapting the flow of ascending information to the adaptative needs at each moment. In this way, our brain manages to hear what it wants to hear and can select the information that is relevant to adapt to the environment. So, from the auditory cortex, there is a projection of axons to the medial geniculate body and the inferior colliculus. But at the same time, the auditory cortex projects directly to the inferior colliculus, to the olivar complex, and the cochlear nucleus. Also, the colliculus projects directly to the superior olive complex, and the superior olive complex projects to the cochlear nucleus and through the olivocochlear bundle directly to the cochlea. So now I want to introduce Kelly in this webinar.
Daniel. I'm going to reintroduce, take a pause here and reintroduce Kelly into the conversation. Dr. Kelly, thank you again. If you don't mind, can you share with us a bit about your overall strategy with your tinnitus patients and how you've come about to incorporate Levo into your protocol?
Yeah, absolutely. Thank you so much for having me here today. So whenever tinnitus is brought up in my clinic, I like to look at it holistically because, I take it as a side effect of something or things. And after doing a full case history, a full audiologic evaluation, doing testing otoacoustic emissions to see what's going on, and depending if hearing loss is involved or not, we may go the route of hearing aids with tinnitus treatment. We may just go Levo. We may do a combination. But I always tell my patients, there's no golden standard. So it's different for everybody. And even with Levo, if someone's a potential candidate, I always make sure they're aware that you have to be a specific candidate and you have to be realistic with the process or else it's not going to work.
Excellent. You talked about a specific candidate. Can you go into a little bit more detail about that?
Sure. Is this on the next slide, that one?
Nope. Just in your general view, what do you consider a candidate for?
Yeah. So there's three main things that I look for. We want to make sure, number one, that their hearing loss is not severe enough to where the output from the Levo system won't reach it, because we don't want to add further hearing loss. So there are output levels. Number two, can we sound match exactly the sound in the person's ear or ears? And it can be different in each ear. That's the biggest one. that, and the third one, which is, well, I guess this is the biggest one, is the realistic expectations. Understanding that this is going to take time. It isn't always going to be easy at first, but if you stick with it and you truly are a candidate, I've seen a lot of great success.
Excellent. Thank you for sharing. And in your opinion, what are some general advantages that you see Levo system providing to your patients?
So a lot of my patients don't want to hear more noise in their head, the same sound or different sound in their head while they're awake during the day. And so when we changed the concept and discussed, you're taking one sense, so, you're sleeping, so you're hearing the sound regardless. If you have the same exact sound at the same level, there's less annoyance to it. And the process seems to be much more approachable and appreciative versus, as I mentioned, like kind of the daytime noise maskers.
Excellent. Thank you. You did bring up, therapy at night, and that's leading us as a segue into Daniel and his next set of slides here. Dr. Drexler is going to be highlighting why acoustic sound stimulation at night during sleep is beneficial to some tinnitus sufferers. So Daniel, go ahead and take it away.
Well, let me first tell you a brief story. I am lucky to have been born in a small country in South America where since the 40s, there has been a neuroscience lab dedicated to studying hearing during sleep. Being a pioneer in this field worldwide, since the pioneering work of Dr. Garcia-Aust, following the work of Professor Belluti, whom we lost last year, and Professor Pedemonte, 3 generations of researchers have developed extensive knowledge on how the auditory system works during sleep. As I say, I was extremely lucky to do my master thesis in that laboratory, and it was there that, together with Dr. Pedemonte, the protocol for the therapy of tinnitus with acoustic simulation during sleep emerged. In this laboratory, for 70 years, the discharge patterns in response to sound of auditory neurons of all levels of the auditory pathway have been studied. And it was studied in different behavioral states. While awake, just a second, excuse me. While awake, in different stages of slow sleep and in paradoxical sleep. Beginning with the cochlear microphonics, wakefulness, slow wave sleep, and paradoxical sleep, the auditory nerve compound action potential, the cochlear nucleus also at wakefulness, slow wave sleep, and paradoxical sleep, the lateral superior olive, the inferior colliculus, and the auditory cortex. And what's the first incredible thing that we see here is at all levels, all the neurons keep on firing in response to sound during sleep. For example, as we can see it here, in slow wave sleep, in the auditory cortex, there's firing in response to sound. Also in paradoxical sleep, and also, of course, in wakefulness. So, there has been no auditory unit that stopped firing as the Guinea pigs enter sleep. At the center here in this image, we can see a pie chart that show percentages changes of neuronal firing on passing from wakefulness to slow wave sleep and from slow wave sleep to paradoxical sleep. At 4 auditory regions again, so at the auditory cortex, at the lateral superior olive, at the cochlear nucleus, and at the inferior colliculus. And what we see is, again, all the system is processing information. There are changes maybe in the way the information is processed during wakefulness and during sleep, but all the system remains active during sleep. So, why therapy during sleep? Our auditory system evolved along the zoological scale over hundreds of thousands of years. One of its fundamental roles has always been to function as a remote warning system to detect predators, both during the day and at night. During the night, it was always especially useful, for example, to detect a tiger while we were sleeping in total darkness at the bottom of the cave. The auditory system has no eyelids, and during sleep, it becomes the most efficient of our sensory systems. The auditory system works 24/7. So many of the advantages of Levo therapy are related to the fact that it is done during sleep. And again, why during sleep? Well, as we saw in the previous slide, sensory systems continue to process information during sleep. All levels of the auditory pathway remain active while we sleep. During sleep, the stimulus provided by Levo has less competition with other sensory inputs. Therapy during sleep does not compete with other day-to-day activities. This allows a stimulation window of up to 8 hours. Patients are unaware of the stimulation while sleeping. This is very important because it reduces the anxiety related to the therapy. Levo therapy improves the quality of sleep. We have data from a clinical trial that we published in 2016 that shows a very significant improvement in the sleep subscale of the TFI, and this is the data. In this study, we demonstrated that the treatment with Levo, in addition to producing a very significant improvement in 3 psychological tests, THI, TRQ, and TFI, in addition to producing a very significant improvement in those tests, also generated a very significant improvement in the quality of sleep measured through TFI's sleep subscale. The THI showed a mean decrease of 32 points from here to here, and a 65% improvement over pre-therapy averages. TRQ showed an average decrease of 31 points pre-treatment and post-treatment. And this is a 78% improvement. And regarding the TFI, the mean decrease observed was 48 points from here to here, meaning a reduction of 77% of pre-treatment TFI scores. All the subscales showed significant improvements. The subscale for sleep, which was very important for us since the treatment is performed during sleep, showed a sharp decrease from 68.4 points pre-treatment to 13.3 points post-treatment. So there is a close relationship between sleep and tinnitus. If the quality of sleep worsens, the tinnitus worsens, generating a vicious cycle that in turn worsens sleep. The improvement in sleep quality observed with Levo tends to transform that vicious cycle into a virtuous one. All of us who treat patients with tinnitus know that in most cases, the worst moment of our patients is before going to sleep, since the decrease in noise from the environment puts tinnitus in the foreground. The fact that Levo therapy starts before going to sleep gives patients a tool that helps them navigate this challenging moment of the day. So to determine if stimulating during sleep affected the normal physiological architecture of sleep, in the first years of this project, we made polysomnographic recordings of patients with and without acoustic stimulation. In this figure, we see the polysomnography of a patient in which we recorded nocturnal physiological sleep for almost 6 hours. From top to bottom, what we can see here is an hypnogram showing sequences of the different sleep stages through the night. Wakefulness, paradoxical sleep, N1, N2, and N3, different stages of slow wave sleep. And sound stimulation was applied in the first half of the night, in this portion of the night, from here to here. From this arrow here to this arrow here, sound stimulation was applied. And in the second half of the night, sound stimulation wasn't applied. And what we see here is that the hypnogram, the architecture of sleep, remains the same even when we are stimulating the patient. So this is very important and relevant information because with this experimental model, we demonstrated that sleep architecture was not affected by acoustic simulation during sleep. So now, yes, I want Kelly to hear a story from you, from your patients.
Absolutely, yes. So I've worked with several patients over the years with Levo. I found this case to be a very interesting one, and if you're reading her little response, you'll see why. She's an 84-year-old woman, mild to moderate hearing loss. Her husband has hearing aids and wears hearing aids. We tried hearing aids on her. She took them home. She really didn't find a benefit at this time for herself. It was tinnitus that's her primary goal. And so when we went through the process of, discussing what the tinnitus sounds like, is it stable or does it change in pitch, we found out she could be a potential candidate. So she's starting to check things off the list. When we did her sound match, when we did her TFI initially, it was close to 64, which is very significant. She was really bothered by her tinnitus, but the tricky part with her is she didn't sleep well at all. She had trouble sleeping. So this is why I'm adding this one in. She would be up sometimes in the middle of the night. So it was a little bit more unique. Because of this, she would still wear the device at night and use it if she was up and quiet reading a book. I said, just keep the system on. The first follow-up, she was a little kind of going, I don't know if this is going to work, but I'm going to keep on going on. Then I think 2 weeks later, she called and said, I don't know that the sound match is quite right. So after looking at the evolution, her volume started going down. Her tinnitus, the TFI started going down. And I think her tinnitus changed slightly. We just adjusted it by a couple of hertz, I believe. And so after that, and she was like, I'm still frustrated with it. But when we finally had our follow-up 6 months later, her score dropped to 27 on the TFI. It was huge. And she's actually sleeping better now. She's able to sleep at night. This was a non-related tinnitus issue with sleeping, but she's doing better with that. And her quality of life has improved. She wanted to give up so many times, but she's so happy she didn't. And so that's why I wanted to add this case in, because yes, she has trouble sleeping and staying asleep, but she was able to see great success and benefit with the device.
Thank you very much, Kelly. Now, this is very interesting because many times treating patients with tinnitus is keeping on the strength to sustain the patient over the treatment. And this is very important because many times the motivation falls apart and we need to be there to support them. So thank you very much for this case.
Absolutely.
And now the next one is the results of a study that we performed in Montevideo in 2010. We published this work in which we demonstrated that the intensity of tinnitus decreased significantly with Levo therapy from this point to this point after treatment. But the reviewers of the magazines asked us to show that this drop in intensity was correlated with an improvement in the psychological test for the evolution of tinnitus. So in 2016, we published a study in the International Journal of Audiology in which we demonstrated, on the one hand, here, we demonstrated that we obtained an average decrease of 14.1 decibels in the intensity of tinnitus, and that this decrease was also strongly correlated with a drop in the 3 psychological tests that we did simultaneously, THI, TRQ, and TFI. So the pre-therapy average tinnitus intensity of the participating patients was 58 dBs, while the post-therapy intensity was 43.9 dBs, which means a drop of 14.1 dBs, We know that a reduction of 10 dBs decreases the loudness perception by half. So the perceived reduction of loudness was of 62% in average. That involves taking tinnitus from a pre-therapy situation in which it was above normal conversation levels here to a post-treatment situation in which is below the sound of a quiet office. So this is a substantial drop, which leads to an improvement of the patient's quality of life, since the moments of the day in which the tinnitus is above the ambient noise decreases dramatically, thus decreasing awareness. Also, in the moments that the patient is aware of tinnitus, tinnitus is less detached from the noise floor of the environment, decreasing the annoyance. So to better understand what that intensity drop means, and now please, if you are using earbuds, be careful not to use so loud, because we are going to reproduce sound here, okay? So I will give you just a few seconds to put the volume not so loud. And to better understand what that intensity drop means, this is how tinnitus would be heard at 59 dB, the pre-therapy average. And this is how tinnitus would be heard at 44.5 dBs. That means the post-therapy average. So now let's imagine we walk into a noisy coffee shop with tinnitus at the pre-therapy intensity. In this situation, tinnitus is clearly heard over the ambient noise, even though that the coffee shop is a very loud ambient. So now let's imagine that we walk into the same noisy coffee shop with the tinnitus at the post-therapy intensity. And in this situation, the tinnitus falls below the ambient noise. So this is a way of understanding what happens inside the brain of our patients when the tinnitus has a decrease of intensity of 14.1 dBs. In this figure, we see an example of a volume evolution graph provided by Levo. On the x-axis, there are the days of treatment, and on the y-axis, the intensity at which each night simulation was performed. This is a very successful case. I wish all the patients were like this. This patient started with around 70 dBs of tinnitus, and he reached almost 33 dBs in 3 weeks. This is not the usual situation. Usually we have to fight, as Kelly was saying with her presentation, with the case she brought. Usually it's more difficult, but this kind of graph is extremely useful to monitor the evolution of therapy and generate psychological reinforcement for our patients. And crossing this data with the scores of the psychological tests helps a lot to make decisions in relation to the evolution of the patient. Let me now introduce the Levo system. Levo was designed to perform the therapy of tinnitus with acoustic simulation during sleep. It consists of 3 parts. First, the Levo Manager device, which allows the therapist to design highly customized pitch-match sound, and also allows to store data on patients' evolution through therapy. The second part is the patient's device, which allows him to stimulate every night with the sound designed by the therapist. Each night, the patient calibrates the simulation intensity, setting it slightly above the perceived volume of the tinnitus before going to sleep. And the third part is a pair of high-fidelity earbuds with flat response in the range 100 Hz to 16 kilohertz. Those earbuds were specially designed for comfortable sleeping, and the entire system is precisely calibrated. So what are the advantages of the Levo therapy? We can divide them in two groups. The ones that are related to the type of acoustic simulations, and those that are related to the fact that acoustic simulation is performed during sleep. We already talked about the advantages of simulation during sleep. Now we are going to focus on the type of acoustic simulation. Levo allows to design what we call the individualized acoustic receipt, which is a highly customized sound that reproduces the frequency and intensity characteristics of the patient's tinnitus. Each tinnitus is unique, as if it was a kind of acoustic fingerprint. Levo allows to combine 5 different types of sounds and adjust the variables of each one of them in order to be able to reproduce each patient's acoustic fingerprint. Levo delivers highly precise acoustic patterns that are fundamental to produce a more efficient induction of neuroplastic changes in the auditory system. In recent years, we have learned that the best results with acoustic simulation are achieved when sound stimulation includes some of the spectral and/or intensity characteristics of the tinnitus. This was stated by Skyte in a study from 2010. And we also learned that incorporating tinnitus pitch and/or range of hearing loss is effective in reversing tinnitus-related neural hyperactivity. This was stated in a classic study by Noreña and Egerman. So, what are the differences between customized and non-customized sound? First, the purpose in non-customized is to reduce adverse reactions by masking, while in customized is to generate permanent changes mediated by neuroplasticity. The goal in non-customized is to get the patient accustomed to tinnitus, while in customized is to reduce intensity and to achieve desensitization. The type of sound is unmodified sound like noise, music, etc., while in customized, it is sound created based on individuals' tinnitus. Customized sound depends on the precision of acoustic patterns, and its goal is to reprogram the auditory pathways. This is a study from 2017 by Theodorov et al. From Dr. Henry's group at the NCRIR in Portland, the VA hospital in Portland, in which 60 patients were divided in 3 different groups. The first group was treated with a bedside sound generator. The second group with Levo system, but with a non-customized sound of the patient's choice. That means the patients were told to choose, for example, sea noise, wind noise, white noise, and they slept with the Levo system, but with a non-customized sound. And the third group was treated with Levo system with the individualized acoustics receipt, that is the customized pitch match sound. The result of the numeric rating scale, those results here, showed that the group treated with customized sound obtained better results in relation to the reduction of tinnitus loudness. In turn, this protocol demonstrated that the best results were not only achieved by applying the treatment during sleep, but that the precision of the customized sound makes the difference. And lastly, this is a preview of the results of an analysis that we are currently doing of 141 patients from the Montevideo Tinnitus Center database treated with Levo between 2015 and 2022. This is a combination of the results of all patients that used the treatment between 3 months and 1 year. 67% showed an intensity reduction. But when we break into 3 different categories regarding the time of treatment. At 9 months, 85% of them saw an improvement, with 27% achieving a reduction between 1 and 5 dBs, 32% between 5 dBs and 10 dBs, and 25% a reduction greater than 10 dB. So what does this data tell us? Well, neuroplasticity is a biological process, and biology is slow, so we have to be patient. We have to support our patients through the process, and it takes time. And taking into account this data, we developed a protocol that lasts 1 year, and that I would like Matt to introduce the protocol of Levo treatment.
Thank you, Daniel. Yeah, as you mentioned, obviously biology, neuroplastic changes takes time, and every patient is a little bit different, as I don't have to preach to the choir. So typically a duration of Levo therapy is anywhere between 6 to 9 months, a year, sometimes, broken down into 3 different phases. During the adaptation phase, your patient begins to get used to wearing the device while sleeping, learning where to set that volume intensity of the sound therapy, getting used to wearing earbuds at night. And so then once comfortable and adapted, patients will then continue the process through the continuous stimulation phase, where they would listen to their sound therapy nightly, on a nightly basis. And then finally, your patient will begin to wean off that device during the detachment phase. So typical protocol there. Kelly, do you have anything to add? Can you share what's your typical protocol with your patients going forward?
Absolutely. So I try and keep a typical protocol, but of course, every patient's different. So sometimes I'm a little more TLC with them. So usually it's a 1-week follow-up phone call. If all is going well, we definitely set up a 4-week or a 1-month in-person check. We redo the TFI, we reassess, and I look at the evolution of if there's been any changes to volume or sound, if they're having any issues. Then after that, I sometimes do a 2nd month follow-up in person. It really depends. But the goal is to have it, as you're seeing on the screen, 1 month, 3 month, and then I sometimes will do a 6 month as well, because I like to track that change. So this guideline or timeline is great. I just vary it depending on the patient slightly.
Obviously, yeah, every patient's
some need a little more support, or they're not fully right. They matched their sound the right time initially. So things like that pop up.
Excellent. Thanks for sharing.
Mm-hmm.
Go ahead and go to the next slide there for me. A few upcoming items I'd like to share with you, and then we'll open it up to Q&A. We will be attending a couple of industry conferences this summer, as well as hosting a future webinar on the patient experience the end of next month. Definitely be on the lookout for that invite coming up. We're going to have a couple of Levo patients on our panel to discuss their patient journey and answer some questions. Also, Daniel mentioned we are rolling out our continuous learning platform in the very near soon to both Levo partners and their patients. Understanding that we know how important extra touch points counseling is for a patient's tinnitus journey. These online learning modules will help you share with your patients additional support, education, anything from managing expectations, what is neuroplasticity, to relaxation techniques, attention training. Again, just short self-driven learning modules that we'll send off to you to share with your patients throughout their Levo journey. So definitely be on the lookout for these in the coming weeks. At this time, I am going to open it up for a few minutes of questions. Again, if you do have any questions, feel free to write them down in the Q&A, and we'll get to them as many as possible. Again, this will be recorded, and we will have a link sent out to you following this webinar. So I'll go ahead and start and open this up to Kelly. I believe you touched on this in the past, but if you can revisit your approach to a typical tinnitus consult, what's involved, what does that look like at the beginning stages?
Yeah, so I definitely have them fill out a TFI at the initial consult. We do a full case history. We look through their medications. We talk about trying to find when and if they know when the onset occurred. We talk about describing what it sounds like. Does it change? Do we know if things trigger it? We do a full workup, normal evaluation, otoscopy, impedance, audio, speech, pure tones, speech and noise, OAEs. And we come back and reassess, what's going on after that and kind of try and piece together, is it hearing related? Is it medication related? Is it a little bit of both or something else that happened? And once we have that, we kind of start trying to rule in or out what's going to be most appropriate for them. So I always have a few different thoughts in the back of my mind. Sometimes it is hearing aids for patients. Sometimes they just are not ready for hearing aids and they solely want to treat their tinnitus first. And sometimes it's a combination of both. So that's kind of how I start the general consultation.
Excellent. Thank you. Daniel, anything to add on that?
Well, I think that hearing aids are a great thing and they are a great solution for many patients, especially those ones that has a mild or not mild, profound hearing loss. But there are many cases in which patients has tinnitus and they are not candidates for hearing aids. And the last thing they want to hear when they come to our office is that they need a hearing aid for the tinnitus if they don't need them for the hearing loss. And the other thing is that most of the hearing aids available in the market don't give a lot of amplification above 6 kilohertz. And we have studied our database in Centro Tinnitus Montevideo, and more than 70% of our patients have their tinnitus above 6 kilohertz. So maybe for those patients also, the hearing aids will not provide the best solution. So I think that what I do with my patients is I have as you said, I had a wide open window of opportunities. Some patients are good on hearing aids. The other ones, I use the Levo system, especially in those ones that they have mild or no hearing loss, or they are not candidates for hearing aids. And sometimes I also use both of them together, because there are patients that they like to use the hearing aid during the day, and before going to sleep, they adapt the Levo system and they sleep.
I'll agree to that.
Thank you both. Question came up about longitudinal studies regarding lasting neuroplastic changes for a year or so. Daniel, are you aware of any lasting effects, or do patients typically have to go back post 1 year? Can you talk about a long-term typical patient in your experience?
Well, we started treating the first patients in 98. It was in the previous century. So now we can see them. Many of them already passed away, but we have patients that still are coming to our office. And usually what happens is that after the year of treatment, they remain with the tinnitus in the situation that is compensated, in a compensated situation. But sometimes after a year or 2 years, they go to a party or they have some stressful situation in their lives, or, well, sometimes it's difficult to know what provoked the compensation of the tinnitus, and they come again to our clinic. But the good news are that we don't need to stimulate them again for a whole year. Once the patient created a new footprint, that is why I talked in this example of the soccer field, of the footprint. Once they created a new footprint inside the auditory pathway, if they get outside of this footprint and the tinnitus gets high again, they stimulate for 1, 2, or 3 days and they get back inside the footprint we created with the therapy. So this is very important because this footprint, and this is what we notice here after 20 years of using the system, this footprint is very stable. And once the patients get inside this footprint, they tend to stay inside the footprint.
Excellent. Thank you, Daniel. One question came up about...
excuse me, Matt, this is a very good question, because of course, when we started the treatment, we didn't know if we were going to achieve neuroplastic mediated changes. So after 3 or 4 years in 2005, 2006, we started to realize that those changes were stable and they endured in time, even after we finished the treatment. So we were very happy with these notices. And of course, it's a very good question because it's the first question we had when we started with the treatment.
I'll just jump in there real quick and add on. A couple of years back, I had a patient doing great, got off, I wasn't using the system. 4th of July came around, fireworks came about, loud noises. And so the tinnitus came back from the fireworks. And so we were thankfully, it was a different tone this time. So we did have to redo the sound match, but we reintroduced it and it didn't take as long.
Excellent. Thank you both. One final question here regarding some challenges, or if there's any general challenges with customized sound therapy or tinnitus therapy overall. I know you touched on managing expectations, but anything else or any points of emphasis of how to overcome some of these challenges when dealing with tinnitus patients?
Kelly?
Yeah, I think it's hard to describe what you can hear and no one else can. Having tinnitus myself, I can definitely say I can describe it in 500 different words probably sometimes. So it's really being able to have the communication and help them. But the nicest thing I find that really helps is because we're sound matching, if they can't verbalize what they're hearing, we're starting to give them different options. Okay, does it sound more like this or does it sound more like this? It's not exactly like an eye test, but it kind of is because we're trying to hone in on that sound or sounds. So I find that extremely helpful because if they can't describe it, we can at least have a starting point. Another amazing thing is when we find the spot, like if this patient is a legit candidate and they have their significant other with them and they can play out loud on the device what they're hearing and how loud it is, it can be mind-boggling sometimes for the significant other who may be like, I don't know what's wrong with them. I don't know what tinnitus is. I'm not stressed about it. So it's kind of I like the approach in that sense to help break down the difficulties in describing it and then sharing it with others, their loved ones.
Excellent. Thank you, Kelly. One question.
I think, no, just regarding this question.
Okay.
I think that the most important thing in tinnitus therapy is empathy. To be able to build a bridge of empathy with the patient to understand what he's suffering. Those patients usually came to our office after being in 6 or 7 different doctors' offices where they were told that there was nothing to do. And they come, in a very desesperating state. So to be able to build a bridge of empathy is very important. And if you design the sound and you show the sound to the patient, and the patient says, this is what I'm hearing, this is a very strong bridge of empathy, because it's the first time for this patient that he knows that someone on the other side is knowing approximately what he's feeling. And usually our patients, what they do when they come home, they show it to the wife, to the kids, to everyone, this is what I'm hearing. I want you to know why I am in this mood, why I feel so desperate, and why sometimes it's not so easy to communicate with me because I am hearing this all the time. So I think that this is a very important tool to have a way of creating a bridge of empathy with our patients.
Thank you both. Just a couple things in the question tab and answer tab. Studies comparing Levo to neuromonic system. At this time, no, there are no head-to-head studies comparing Levo to that specific device. The studies that we shared here are the ones that we have currently published. Question for you, Kelly. Do you typically do testing above 8K during your initial consultation?
No, I do distortion product OEEs, DPOEEs, and I go above in the high frequencies there. And then if we do sound matching on the Levo system, we can go beyond the high frequencies that we can test on an audiogram. So I use that.
Perfect. Thanks for clarifying. Daniel, one question about the specs for the maximum output of the earbuds. Are they're at each frequency?
Yes, it's in all the range from 100 hertz to 16 kilohertz. There is a maximum output of 85 dBs SPL. So, for example, when we set the volume of the acoustic receipt, the patient has only the possibility of going above 6 dBs of the set volume. For example, if a patient has a acoustic receipt at 4 kilohertz, let's say 60 dBs, he can only go up till 66. And for example, if the same receipt is at 80, he cannot reach 86 because at 85, it would stop delivering sound. And this is very important because we know that this is the limit in order not to create harm in the audition of our patients. And also above 80 dBs, we don't use the system all the night. We reduce the amount of hours also in order to be able to prevent damage. And this is very important. You know, we always use the same system with the same earbuds, and they are all calibrated. The iPad is calibrated with the iPod, and the iPod is calibrated with the earbuds. So we are sure of the intensity we are delivering inside the ear of the patient. I think that sharpness here, precision here, is very important in order to protect the patient and in order to be able to generate neuroplastic mediated changes.
Excellent. Thanks, Daniel. As you mentioned, yes, so the device itself does go up to 85 decibel. We do recommend in the patient type, you know, it's more geared towards those mild to moderate or no hearing loss patient. Whatever you set the baseline of the sound match to be, patients do have the flexibility of increasing that volume by 6 dB of whatever that baseline is each night before they go to sleep. And then they're instructed to set that volume right at that same level as their perception of sound. I think that's one thing. One other question came up about remote pairing. At this point, any adjustments that is needed to the sound match does have to be in person via Bluetooth, and then transferring that sound from the manager device over to the patient device for them to adjust the volume on a nightly basis. So at this point, let's go ahead and go into the next slide, Daniel, and I'll recap and thank you again, everyone, for attending this session. I really appreciate the dialogue and the introduction here with Dr. Kelly Breese and Daniel, Dr. Daniel Drexler. Really appreciate both your insight and sharing with us today. If you do have any additional questions, or if I did not get to your question here in the session, I will be reaching out and giving you an update, but please feel free to reach out to me directly. My email or phone number here is on the screen, and then the QR code links to my calendar if you want to schedule any type of follow-up meeting or demo of the device itself. So again, really appreciate all of your time. Look for that invite for the next webinar coming up end of next month, and hope you all have a wonderful afternoon. Thank you again.